Guys, welcome back. Today we shall be discussing recall-based medicine MCQs of the recently conducted Neet PG 2022 exam. Let's get started. The first one said image-based one, integrated one. It said CSF specimen of the patient was shown and it showed mononuclear cytosis, which points towards probably that the lymphocytes are increased. And then he says presence of a moderately low sugar values. When it comes to pyogenic meningitis, most of the time the sugar values are dramatically reduced and most of the time can even become zero. So here he's talking about moderately low sugar with the elevated protein values, which means that at least two options can be easily ruled out. That would be aseptic and viral meningitis, because when it comes to option number B and C, both of them, the sugar values would be normal in the CSF. As far as A and B are concerned, the look of the CSF does not look to be turbid. And then what do I spot here? What I spot here is a very characteristic manifestation. This looks like, something like I would say a disintegrated basketball net. The basketball net, it's shredded, it's just lying in a corner. So this is what we call as a cobweb coagulum. And if you put the 2 points together, that's going to be the presence of lymphocytes. Anyway, in an Indian exam, whenever they talk about lymphocytes in the CSF, you first always have to think in terms of tubercular etiology. And what better if it gives you a cobweb coagulum image along with this. I personally feel that you don't need the second image, which is shown here. They probably would have made a smear from the CSF of the patient. In fact, they use this cobweb coagulum. The microbiologist would tease out this cobweb coagulum and they'll make a smear and then they'll fix it with ZN stain and they would be able to, look at the acid fast bacteria that helps us in diagnosis of this particular case as option number D. And as I've always highlighted, you see, whenever the sugar values are dramatically low and there are neutrophils present, turbid CSF, it gives acute bacterial meningitis a priority. But in this case, with the presence of all the facts that I've said, the answer becomes, in my opinion, a relatively easier one to pick up as compared to the other questions that were asked. Coming to the second question, he said a known case of chronic liver disease with ascites presents with abdominal pain and tenderness, and the ascitic tap of this patient shows 600 neutrophils per cubic millimeter. You see, neutrophils have no business to be in the peritoneal cavity in the first place. Forget about peritoneal fluid. So he says, which of the following is a likely etiology? Considering the background information of chronic liver disease with ascites given, what would have happened in this case is that there would have been a transmigration of E. coli via the edematous bowel wall. In fact, these E. coli would first migrate to the lymph nodes and from there into the peritoneal cavity, and then the security system acts and you have is a fight between the bacteria and the security system, and that explains the peritonitis component here, that explains the symptoms of this patient, that explains the tenderness in this case. And the cutoff for diagnosis of this condition is anyway well known by you. I both put up a Harrison reference here as far as, and whatever I have taught, that is more than 250 neutrophils present in the setting of chronic liver disease with ascites, which helps us narrow down the diagnosis to this patient as option number C. As far as option number A is concerned, tubercular ascites, history does not correspond to it. I mean, you would not consider two differential diagnoses. If already a guy is having CLD with ascites, you would be thinking in terms of development of complications of cirrhosis. So making a second diagnosis along with this would not make sense. And then I did say lymphocytes would be increased here. For malignant ascites, again, you see, the possibilities are relatively lesser, because suppose he would have been talking about a lady with ovarian cancer or a stomach cancer patient presenting with gross abdominal distension, I could have considered malignant ascites, though obviously it will require a cytology finding to pick up the cancer cells. And for chylous ascites, the fluid will be milky white in color, and more importantly, apart from being milky white, you will be able to demonstrate the increased amount of triglycerides there. So a couple of options can be easily ruled out, and then between B and C, I think spontaneous bacterial peritonitis based on the cutoff of 250 is answer here. The next question said 82-year-old man with hypertension comes with acute onset of breathlessness. I presume that non-compliant word was also given, though some people, I did not include this in this slide because some guys said, no, sir, there was nothing like this. But still, my point is, in any person with hypertension, there can be a development of left ventricular failure. And the X-ray gives credibility to the same because you can notice the battering pulmonary edema component. And since the patient is going into cardiogenic pulmonary edema, I would be using LMNOP, that is less 6 morphine nitrates, oxygen and positioning for handling this fellow. And in fact, that's the only mnemonic that is given in Harrison, LMNOP. Otherwise, it just gives data, data, data. So what I'm going to do in this case is start him on IV nitroglycerin drip. It will reduce the preload, reduce the afterload, and thereby reduce the load on the heart, and the performance of the heart would be increased. The answer to this question would be option number C, and the remaining options can be ruled out because anyway we're not dealing with asthma in this case. So B and D were, I think, dummy choices, and A, antibiotics are not required in this patient who's a known case of hypertension, so fairly easy one. The next question said adult patient complains of palpitations and presents with irregular pulse, very characteristic. Two differentials of irregularly irregular pulse can be atrial fibrillation and multifocal atrial tachycardia. Is giving you a pulse deficit. Now the point is, pulse deficit means that the heart rate and the pulse rate will not be matching. Pulse deficit more than 10 is always significant, and this basically tells us that because of the irregular rhythm, you may not be able to count some of the impulses that you are counting in any of the peripheral pulse. The patient's hemodynamic status was that the BP was not crashing. I mean, he was not a crashing patient. And he said, which of the following would be found in these patients? So the bottom line is, in atrial fibrillation, the atria are not generating power. If you downgrade the power, well, JVP is related to waves, right? So atria have to generate force to cause a presence of a wave, and once it would be twitching, there would be presence of absent A waves. As far as Canon A waves are concerned, AV dissociation, and the differentials are pretty visible on the slide. So this was, I think, just a correlation between physiology and medicine. And the answer to this question would be option number A. The subsequent question said, a patient presents with digoxin toxicity. The pulse rate was 54 per minute. I did ask a lot of people, which looks to be a little, I would say, on the higher side of what it should be, because there was a ECG evidence of a third degree heart block. Now, what digoxin toxicity is causing is simply that it is causing the vagal discharge to increase, because you very well know digoxin has a vagotonic action. So because of the stimulus of the vagus node, the AV node is not being able to do its job, and therefore what's going to happen in this patient is that the SA node will be able to control the atria. So the atrial rate of this patient can be anything between 60 to 100, but because the impulses would not be conducted down, the bundle of Fizz will become the boss of the heart. And the bundle of Fizz, the firing rates are definitely on the lower side. So this person would be having bradycardia, and he says, what would be the best management of this patient? If we look at option number B and D, lidocaine and phenytoin, both of them, option B and D, are useful for management of ventricular bigeminy, which is the one of the commonest tachyarrhythmias that can be seen in these patients. And ventricular bigeminy can then degenerate into ventricular tachycardia. My point is that if you look at option number B, D, and option number C, all of them are basically designed for management of any tachyarrhythmia in a patient. Phenytoin, well, I can say like this. I always say this, the only example in cardiology where they are using a CNS drug, because phenytoin is used in epilepsy, but phenytoin is used in digoxin toxicity for ventricular bigeminy, because it is a membrane stabilizing effect. So B, C, and D, in fact, they're all designed to handle a tachyarrhythmia. So these options can be ruled out, which leaves us with the only one, and that becomes the answer to this question. But before I mark it, I would just like to show you a reference here also. As far as current medical diagnosis, CMDT, is concerned, CMDT mentions the fact that if a person has consumed a large number of tablets of digoxin, and in fact, I think a couple of guys also commented here that the person had consumed about 8 tablets. And the question also mentioned that the strength of each tablet was 0.25 milligram. Even if that information is not given, considering that with digoxin toxicity, he has mentioned the word third degree heart block, that gives credibility to the diagnosis of this patient and the answer to this question, in fact. But my point is, with digoxin toxicity and the vagotonic effect, there could be severe bradycardia. And for this person, initially we shall be using atropine and TCP, that is transcutaneous pacing. If it doesn't work, then subsequently we will have to go for digoxin specific antibodies, which we commercially know as digiband. Otherwise, another table says digoxin toxicity, life-threatening instances, you will have to use digoxin when, or digiband when digoxin toxicity is causing bradycardia that is non-responsive to atropine. In fact, in this question, I did anticipate that he might have talked about atropine, but was not in the options. So considering that the textbook mentions the fact atropine with the atropine being given, and in spite of that, there is a bradycardia present, which is causing blood pressure to become low, either a second or a third degree heart block, we should be going in for a digiband in these patients. So the answer to this question is option number A, and the two references are provided to you from two different books, so that we are very clear. And the logic that I used, suppose I'm not aware of all this theory, the logic is simply that when it comes to B, C, D, they're primarily used for tachyarrhythmias. Moving to the next question. The question said a 74-year-old man presents with palpitations, coronary artery disease history was given, and the blood pressure of the patient was about 120/84. And what I can see here is presence of a broad QRS complex tachycardia. The heart rate of this patient would be something like 300 divided by 1.5 large squares. So that works out to a fairly fast rate of 200 beats per minute. Holding on these rates, I anticipated that the BP of the patient will begin to crash, but he has given us a clinical presentation of a stable ventricular tachycardia. Now, in any patient who's having a stable ventricular tachycardia, the drug approach would be in the following format. If there is evidence of structural heart disease, like this guy, he's 74 years of age, I did confirm whether the age group was given to be of geriatric age group or not, because in geriatric age group, atherosclerosis would contribute to CAD, and these patients might be developing even a ischemic cardiomyopathy that they may not be aware of. Now, if there is evidence of structural heart disease, and if there is absence of structural heart disease, the answer would change. If this was a younger patient, if there was no evidence of any structural heart disease, there was no CAD given, then I would have thought in terms of even beta blockers in the patient. The scenario in which beta blockers are given in patients of ventricular tachycardia could be an acute onset ventricular tachycardia in the absence of structural heart disease, or another term that is given in Harrison where beta blockers are mentioned is outflow tract VT. That means that this is not the standard VT that we encounter with conditions like, let me say, coronary artery disease or a patient who's having a structural damage. On the other hand, with structural heart disease, I'll show you the Harrison reference also. He mentions amiodarone should be used for chemical cardioversion in the patient. And considering the fact that at the moment the BP is still stable, but he may not remain stable future, should I go in for oral preparation or should I go in for an IV preparation? So we should be going in for IV preparation, and I'll just show you the reference for the same also. With respect to one, why amiodarone was selected, because the textbook says if structural heart disease or if any kind of concomitant heart disease is present. And then the ACC, the American College of Cardiology table of with respect to management of ventricular tachycardia mentions the fact that any patient having a sustained monomorphic VT. Now, why am I calling it monomorphic? I'll just go back in the slide once again. The amplitude of most of the QRS complexes was more or less equal. I mean, if you look at the amplitude of these complexes, there could be some, fluctuation around the baseline. That could be because the stylus may not be, working properly. But otherwise, most of the QRS complexes are almost of the equal amplitude. And you can also see that characteristic feature that I always speak about. In fact, I'll just move my slide. And one of my students pointed, sir, that I could in the downslope. You see, anything that goes up is R, anything that comes out is S. In the downslope of S, there was this characteristic Josephson sign. Not that Josephson sign will make any change in the treatment of this patient or for the management of this patient, but one, we had a monomorphic VT with a characteristic Josephson sign. So this is what the table says. We will talk about this from the perspective of blood pressure. If the person is hemodynamically stable, then if there is structural heart disease present, the following approaches are to be used: cardioversion, procainamide, and amiodarone. And the beta blocker that is mentioned here is not metoprolol. He's mentioned a class 3 antiarrhythmic. In this case, that is going to be sotalol, which can be used here. So the message is that only in certain scenarios are you supposed to be using, I would say, metoprolol in these patients or beta blocker. Like one would be a patient who's having an outflow tract ventricular tachycardia. Now, nothing like this was given in the options. So I think we can keep it simple and straightforward rather than making life difficult for us. And the answer for this question should be given as option number C. That would be chemical cardioversion in this patient using IV amiodarone. Moving ahead in our discussion. Moving to the next question, it said which of the following is used to decrease the concentration of extracellular potassium? Option A said lactic acid. I did have had a chat with people. I mean, initially got a feedback. Option A was bicarbonate, but I think that was a different MCQ where TCA toxicity was asked and bicarbonate would be used. So option A was lactic acid. Lactic acid, one being given to a patient, does not make sense because if you look at option number A, then this rule is what I've said. pH and potassium always have an inverse relation. So if I'm gonna give lactic acid to the patient, the pH will fall and the potassium will spike even further. So that's the logic by which I'll be able to rule out option A. Then is atropine. Now the point is potassium slows the heart. Potassium slows the heart. So slowing of the heart by potassium results in development of bradycardia, and therefore atropine makes sense. So I will keep this in the options. Glucagon I will rule out because what I want to use in my patient is actually an insulin drip by which I'll be able to send potassium into the cells. So A and C have been ruled out. We are left between atropine and epinephrine. Now, my point is ultimately one, following the bradycardia component, there could even be a diastolic arrest. I mean, I always say that statement potassium causes a diastolic arrest. So, to counteract that, I can be using epinephrine. And in fact, the wordings of the question were not that how would you handle this particular situation. I mean, this will occur. So, atropine makes sense. But at the same time, the question was rather asking you which of the following is used to decrease the concentration of extracellular potassium? I initially had the wordings. I mean, when I went through this, the first time people said, sir, hyperkalemia treatment was asked. And I thought, okay, why not bradycardia and then atropine? But the point is, the question said, how do you decrease the concentration of extracellular potassium? So let me give a short explanation, 30 seconds, and then I narrow down to the answer. You see, during the discussion of hyperkalemia, I said we use salbutamol. And the dose of salbutamol that we use is almost 4x of what we use standard in asthma management. So why are we loading the patient with such a large amount of salbutamol? Because it's going to cause tremors, it will cause tachycardia. So would it not cause distress? Yes, it would. We deliberately are using lots and lots of salbutamol because it will cause sympathomimetic stimulation, and this sympathomimetic stimulation would then be acting on the beta 2 receptors which are present on the muscles. And well, what these beta 2 receptor activation of the muscles would do is that it is going to send potassium into the cells, and when I send potassium into the cells, my problem is handled. So salbutamol has an adjunctive role along with insulin. Why? Because it causes that side effect of sympathomimetic stimulation, and the same thing can be used here also. So I said 2 points justifying my answer for this question as epinephrine. Point number 1 would be that it would help me neutralize this, I would say, the relaxant effect of potassium on the heart, or when it's slowing down the heart. And the second advantage would be that it will also send potassium into the cells, which was the primary aspect that was asked. So considering the two options in this particular question, the better answer for this question would be given as epinephrine, though atropine made sense in case, he just mentioned that there's a dangerous bradycardia occurring in any patient who's having a dangerous hyperkalemia. Once we're sorted with this one, the next question was for prophylaxis for infective endocarditis. A 25-year-old guy with dental caries is undergoing a dental extraction. We would be giving ampicillin to this patient 1 hour before the procedure. The question said, which of the following will not be needing prophylaxis for endocarditis? So before we go into the options here, let me just quickly make you recall when are we gonna going for prophylaxis. Well, anybody with an artificial heart valve, I am gonna use a prophylaxis. Anybody with prior endocarditis, yes. And then congenital cyanotic heart disease comes 3 times in that indications. It could be unrepaired or completely repaired, or incomplete repair of congenital heart disease, and a valvulopathy. That's directly from the table in Harrison that I have discussed this aspect, and now we will be in a better position to understand the options here. Option A says previous history of endocarditis. Makes sense. The guy is already having a valvular damage. I don't want to accentuate it. So I would be going in for prophylaxis in this case. Artificial heart valve. Maybe the word was prosthetic heart valve. I mean, I've written word artificial. Some people said prosthetic, some artificial. I mean, the English word still implies that there is a heart valve which is not of endogenous origin. And I mean, some words might be different from what actually came in the exam. So I am trying to, replicate what a student after the exam would tell me, because maybe you may not recall the word prostatic given. Then was untreated cyanotic heart disease and ASD that are left. Now, my point is, one of the very common cyanotic heart disease is, let me say, tetralogy of Fallot. And tetralogy of Fallot has a ejection systolic murmur. That means it's a high pressure shunt. Whereas ASD, the pressure difference between the left atria and the right atria is only 4 millimeter of mercury, which means that it is a low pressure shunt. The very basic fundamental aspect that I've taught with respect to infective endocarditis is that the chances of development of infective endocarditis in a person is directly proportional to the pressure gradient in the heart. You see conditions like mitral regurgitation, you have a high pressure gradient. So therefore, they are more predisposed to development of infective endocarditis. And before I mark the answer, which would have become very obvious, I think this question is just a modified version of the previous old MCQ that used to come in the exam, that which heart disease has the least incidence of infective endocarditis. We used to answer ASD, and the same question has been asked in a different way by describing a patient undergoing a dental extraction for dental caries and a root abscess or a pulp abscess. The point is that if the pressure gradient is less, that the chances of development of endocarditis would be lesser. So the correct answer for this question would be ASD. And for option number C, I can just show you the Harrison reference. I mean, why not only the things that I have said? I mean, if a person is having an unrepaired cyanotic congenital heart disease, then the shunting in the heart, right to left, is obviously present. But there is a subpulmonic stenosis that causes ejection systolic murmur. So to create a systolic murmur, you need a pressure gradient, and that pressure gradient explains the increased risk of infective endocarditis in the patient, which helps me sort out between option number C and D for this particular case. The next question was a longish one. It said a female who's a known case of diabetes mellitus and is non-compliant to medication. All our patients are non-compliant on this. They're brought to the emergency room with tummy pain, vomiting episodes, and recent onset confusion. So probably the person, there was loss of fluid from the body, and that could have resulted in low blood pressure also, and there is evidence of dehydration. The workup shows urinary ketones with a blood sugar value of 598. I'm very sure this was the exact value. So considering ketones present, considering random blood sugar of 598 with the tummy pain contributing subsequently to vomiting episodes, and then ketonemia. I mean, the ketonemia component here acts on the blood-brain barrier. No? I mean, why there's a vomiting here? The ketonemia stimulates the vomiting center, and therefore there's very protracted vomiting in these patients. And you might misdiagnose this guy as acute abdomen. This chap is having diabetic ketoacidosis, and he says, what would be the best step in the management of this person? So we did have, initial options like IV fluids. So yeah, I mean, I will initially give IV fluids to any patient with diabetic ketoacidosis, but I do have a much more attractive option there because he's asking the word best there. So I would be giving him regular insulin drip also. Option number B, I spoke to a lot of people, was there words like bolus insulin, because you are aware of the fact that we do give a bolus of regular insulin to all our patients before the insulin drip is started. But I think most guys were of the opinion that the question was just saying, how would you best manage this patient? So option number C makes sense. And long-acting insulin would be used subsequently when he gets out of the intensive care unit. Once he's ready to go back home, that you would be making up a proper chart for this guy and telling him the types of insulin to be used, and you would be prescribing bedtime insulin for this person. It's mostly non-adherence to medication, which is the trigger behind, the trigger why he had this complication was the non-adherence component. The answer to this question works out to be C. I know that we can have a big debate about this with respect to if the bolus word is introduced and what if it is like first line management for the patient. But I did deliver, before coming to you here on social media or in the app, I did talk to people. We sat late in the night and I did have a very detailed discussion with the students with respect to this statement that the question was asking about what would be the best way to manage this patient. The next question said a female patient complains of loosening of one tooth and hemifacial pain, and the patient was previously treated for COVID-19 4 months back. So we would have used maybe steroids in these patients, and that would have resulted in decrease in immunity. And at the moment, there is a loosening of one tooth and hemifacial pain. So what we are thinking is probably there could be a fungal growth in the maxillary sinus, and that could have resulted in the loosening of the tooth. And at the same time, subsequently hemifacial pain because of the extensive tissue damage that this fungus would be causing. So the topic that we are diagnosing at this particular case would be a COVID-19 induced or associated rhinocerebral mucormycosis. Now, when you look at option number A, HB1C, it's not going to help in diagnosis at the moment. And when it look at option number B, that's going to be ferritin. Then ferritin would have been elevated when the person was suffering from COVID-19, not now. So A and B are off the radar. If you look at C, nasal swab for mucor, a lot of guys said, sir, this is the standard answer. In fact, they came to me and they said, sir, this is the answer. Nasal swab for mucor was asked. So I asked them, was it nasal swab for mucor or was it nasal endoscopy with a biopsy? Because my point is that the fungus would be growing inside the sinus. Now look at the history, loosening of one tooth. So the fungus is causing damage inside the maxillary sinus, and your swab is not going to go into the maxillary sinus. So how would you pick it up? Had this been nasal endoscopy with biopsy, cool. I mean, that would have been turning out to be the answer to this question. But my point is, if this was not given, then nasal swab may not be present. Another issue is if a patient is having hemifacial pain, you would write this word nasal swab for mucor and go away, and then the technician will come because the patient will say, I'm having pain on one side. The technician may not put it on that side and put it on the contralateral side. And even if you say, no, I instructed specially my technician to put it on that side also, the fungus could be growing on a turbinate, and your swab, howsoever deep you put it, it might miss the growth on the turbinate. So option number C looks like a attractive option because I am interested in picking up mucor, but my point is the approach is not correct. It should be nasal endoscopy with biopsy. The answer to this question should be given as an MRI head, and that is what we've done in I think the entire, I would say, initial 3 to 4 months in 2021 when we had Delta strain causing mayhem in our country. I mean, a lot of people ended up with COVID-19 mucormycosis. So we were identifying that on the basis of MRI head and subsequently initiating treatment and subsequently getting a nasal endoscopy of the patient done whenever it was feasible. The next question said patient presents with teeth gap widening with frontal bone thickening and foot and hand enlargement. So the words foot and hand enlargement and then frontal bone prominence, they all point towards the clinical diagnosis in this case as acromegaly. And what am I gonna do in this patient? One is because there would be a pituitary adenoma present, so I can get rid of it using a transsphenoidal surgery. Now he is asking you regarding a drug that can actually shrink the tumor and thereby cause a relief. So in these patients, we can be using octreotide, that would be a long-acting one versions, that is lanreotide and pasireotide, that would be acting as somatostatin receptors 2 and 5 respectively. And in fact, I think both aspects were asked. One question was with respect to the recurrence of the tumor that I'm going to discuss subsequently. But at the moment, the approach is medical management with respect to tumor recurrence in tumor initial management, where we would like to shrink the pituitary adenoma, and therefore in these patients we can answer this as option number B, that is leuprolide. Option A would come up in a different question subsequently, so in case you are listening to this and you are pinging me, then yep, there's another question that was having pegvisomant as an answer. Let's focus on that one. It said a patient is having recurrence of pituitary tumor overproducing growth hormone. So in this particular case, we would not go in for surgery. What we are going to do in this case is neutralize the effect of the growth hormone, the receptors per se. I mean, ultimately, if you block the receptor, the hormone will not be able to act. The drug that's going to do this job for me would be pegvisomant. The answer to this question is option number C. Then was a non-rebreather mask, easy to identify. I mean, Hudson mask के साथ में there was an attachment present. We call this a reservoir. This improves the oxygen delivery. I mean, you can deliver up to as much as 80-90% oxygen with help of this. Though obviously high flow nasal cannula will be much more superior as compared to this. But oxygen delivery methods or methodology are to be studied well. The answer to this question is option number A. And if you're on YouTube, then you can just in my channel check out oxygen step up. In fact, the name of the video is oxygen therapy for COVID-19. I actually recorded this separately for COVID-19 at the time when Delta strain was causing mayhem. So you can have a look at that also. And traditional information is anyway in the app. The subsequent question is microbiology based. slash medicine, a truck driver, they love to ask about it. Presents with sudden onset breathlessness. Vitals were given to be stable. I've not incorporated that, but the students told me that it was just increasing the length of the MCQ, and this guy was found to be HIV-1 positive and having a pleural effusion. So one, they love to ask about HIV positive truck driver, and this time instead of asking about a pneumonia, because last time they talked about pneumococcal pneumonia, because traditionally we think it can be Girovesi pneumonia. They asked pneumococcal pneumonia last time, so this time he said, okay, let me give you pleural effusion. Now, there was a culture of the pleural fluid that showed a dimorphic growth at different temperatures with red pigmentation. And honestly, when I read this question for the first time, I was a bit squinting. Okay, is it correct? Red pigmentation. And then I said, okay, let me solve this by exclusion because I did not know this from the microbiology domain. Option A says Girovesi. It causes a pneumonia. I mean, how did I rule it out? Is Girovesi causes a pneumonia, and most of the time, the diagnosis of this can be confirmed only with a bronchoalveolar lavage. So I did speak to people saying, was it pleural fluid or was it bronchoalveolar lavage? They said, sir, it was pleural fluid, not a lavage. And in bronchoalveolar lavage, it would be a totally green screen, where that green screen would be with respect to gomori methamine stain, and then you would be able to see those black cysts. So, as far as the image of pneumocystis jirovacii is concerned, you aware of that from microbiology, so you could have ruled out option number A. B is called as white fungus, though it would be ethically wrong of me to use words like white, and you very well know black fungus is not mucor. I mean, that was again a previous INISET question. Demitaceous fungi are the black fungus actually, but then Candida white. So I am using a color here unofficially to say that I can rule it out in this case, especially the pigmentation part, because Candida I never read produces something red. So I'm left between two options: Talaromyces marfani and then Blastomyces with voriconazole. Now, as far as blastomyces is also concerned, we usually read about white growth, white fluffy growth present. So, though I think you guys are better at microbiology than I would be, and you might have been able to narrow down the answer to this question as option number C. But when it comes to people who are, I would say, microbiologically challenged, then they have to use exclusion to come down to the answer to this one. The answer to this question is option number C. And in case you had some different opinion with respect to these findings, no, dimorphic fungus growth temperatures were different, you can ask me. For Candida, we have the Reynolds brood phenomenon, right? So I thought initially maybe that he's when he's talking about the dimorphic thing, I thought he might be talking about the Reynolds brood phenomenon, but then the red pigmentation did not make sense, and I was able to rule it out. In contrast, the subsequent question was a easier one. We had a smoker presenting with respiratory difficulty. ABGs is showing acidosis. The arrow is going down, and when it comes to the PCO2, it is going up. So considering smoker and the arrows are going opposite of each other, this would be a respiratory acidosis. I mean, much easier than what the previous one was. And don't be under impression every time a smoker is going to have a respiratory acidosis. If he's going to have hyperventilation, if he's going to have exacerbation initially, there could be a respiratory alkalosis in the patient as well. I also asked my students, did he ask anything with respect to compensation? But thankfully he did not. So there were no formulas that were required to be remembered. The next question has a pediatric overlap. A 11-year-old kid with manifestations of rheumatic fever is prescribed 0.6 million units. So I think in the routine lecture talked about 1.2 million units. That's for adult patient or patient more than 18. But in this case, considering the weight of the child would be lesser, it was 0.6 million units. Intramuscular of benzathine penicillin, which is the long-acting format, and he asked what would be correct for secondary prevention. The key for this question is always that they ask words like rheumatic carditis with valvular lesion, and then plain rheumatic fever. Before I focus on the options in this case, let me just talk about what I have talked. I'll show you the Harrison reference also. The bottom line is whether valvular lesion is given or valvular lesion, because it's not necessary, not everybody would be having a carditis component with a valvular lesion present. So the answers and the duration for which the prophylaxis would be required would definitely be changing. And the question was, I think, with respect to plain rheumatic fever. Now the message is, if it's going to be with valvular lesion, then it's 40, or it can even go to lifelong. But in this particular question, let me just show you the textbook reference also here. I mean, the only time when you do, first of all, lifelong is very non-practical, I would say. And secondly, lifelong would be only with respect to if a person has had a severe valvular disease or after a valve surgery. So we will be going in for inputs like this. It's either going to be 40 years or it's going to be 21 years as given in Harrison, and the backups are 10, 10, and 5. Listen to the backups carefully before we focus on the options there. 10, 10, 5. Now we look at the options. Option A said lifelong every 3 weekly. Considering rheumatic fever, there was no carditis, no valvular lesion, no severe MR, no valvulopathy present. So option number A is ruled out due to not only that it is not practical, but also the fact that it was not a rheumatic carditis with valvular lesion, it was rheumatic fever. Option B says only one single dose. Obviously, it is required every 3 weeks. So option number B is ruled out. And then we had two options were for route and two options were for duration. Option C said till 5 years, 3 weekly. This makes sense because for rheumatic fever, I told you either it will be given till 21 years of age or it will be given for a minimum of 5 years, whichever is longer. Or for that matter of fact, it would be given if it was, this is for rheumatic fever. And if I say the word rheumatic carditis, how am I ruling out option number D? Which couple of my students said, sir, I answered 25 because you told 21. 21 was not an option, so I answered 25. My point is, you are answering this considering then for rheumatic carditis. It is for rheumatic carditis that it is 21 years and then 10 years. So when you read this question, why D option can be ruled out is because that is valid for the rheumatic carditis component. He just picked up what is given right at the bottom. Right at the bottom is that 21 years or 5 years, whichever is longer. So the correct answer for this would be option number C. And if there are any issues with the wording of this question, do let me know. I've done my homework and I've come here. Not that I've come with some random choices. All of these are made with help of my dear students only. So option C is till 5 years of age, 3 weekly. And one option had 25 years, which is not to be answered. It's 21 or 10. But then that, why, I'm repeating point number D. Justification point number D is that would be valid for a case of rheumatic carditis. The question mentioned rheumatic fever only. There was no evidence of carditis given. So if you have some issues with respect to the one that I put in the box, the rheumatic fever component, if you say it is rheumatic carditis, then obviously the answer changes. One word changes the entire dimension of the game. You very well know that. The answer on the basis of the information provided to me is the one mentioned here. Okay. The subsequent question said a young female presents with left-sided throbbing headache and she has a nausea, vomiting, aura, and also phonophobia. And the question says, what is the best treatment for immediate relief of this patient? So considering throbbing headache, that would be only on the left hand side, and then there's aura also mentioned. So we are making a diagnosis of this patient as migraine with aura, and the question is asking for immediate relief. Then option number B, C, D, they're all for prophylaxis. So I can be giving triptans for these patients for immediate relief. It could be even a nasal spray, or instead of nasal spray, they could be a transdermal patch, and then obviously there are mouth dissolving tablets also available. The answer to this question is A. This is the kind of question which we wish is always asked in the exam, and like when you read this one, you are like, oh yes, man. I want questions like this. Which of the following electrolyte imbalance? Reading this will bring a smile to your face that, okay, I want this kind of a question, and questions like these to be asked. Straightforward ST depression and a T wave and a U wave. So let me just sketch it. Hypokalemia causes T waves to become negative. So when T goes down, ST also goes down, and then you have is a U wave coming up. So the answer for this one is hypokalemia. And at the moment, I'll not get into electrolyte imbalances and the ECG changes, which are well documented in the app itself. I hope nobody made a mistake in this one. Answer is B, and we move on to the next one. I've described the routine changes. A 25-year-old chap, he had multiple injuries due to a road traffic accident and later had breathlessness with fatigue. Initially I thought he might be talking about pulmonary embolism, but the moment I read that there are going to be a petechial bleed present, then you are going to use the GERD criteria. We have major ones and minor ones, and considering that petechiae would be developing initially in the axilla on the chest wall of this patient, so we are going to narrow down to the diagnosis of this patient as fat embolism. There's no trauma to the jugular vein. Petechial rash is not seen in thromboembolism. There must be some evidence of leg swelling, deep vein thrombosis coming up. And then massive hemorrhage would cause death immediately, not to be presenting with presentation like the one that is given after 2 days. The answer is D. For the next question, it was about a kid after a normal delivery who was having repeated attacks of flexion of the neck over the trunk and jerky movements of the hand. So what he's talking about is salam Caesar. And let me say, if you missed out that salam, because I did that activity, neck flexion and that hand movement, along with this is the keyword. I mean, if you look to or if you listen to EEG and epilepsy component, I know this would be a hardcore pediatric based question, but this is well covered in the EEG and the epilepsy topic. Hips rhythmia means grossly chaotic pattern. I mean, normally we have beta waves when our eyes are open, then we relax, we go to alpha, then we go into NREM1 and we go into theta waves. So all those patterns is what I've described, but here there's a grossly chaotic pattern. So Salam Caesar West syndrome was mentioned, and the treatment for this would be ACTH. The subsequent question said a patient is on antidepressive medication, presents with elevated body temperature, dilated pupils, palpitations, and low BP. I also got a feedback that some people said, sir, pupils in this patient were given to be normally reactive to light. But anyway, that would not change the course of the answer anyway. So let me just write it in case, because I had a divided house, so I have kept both of the aspects here, though this would not dramatically change the answer to this question. Probably if it was dilated pupils, it goes more in favor of sympathomimetic stimulation occurring in the patient. And then there's a broad curious complex tachycardia with a right axis deviation. So what's happening in this patient is that there is a TCA toxicity contributing to metabolic acidosis, and this metabolic acidosis then triggers a VT. The point is, if you are gonna use option number D in this question, it would be like treating the symptom and not treating the disease. Our objective is to treat the disease. Our objective is to neutralize the acidosis component, and to neutralize this, we shall be giving soda bicarbonate. And even without this explanation, I think most guys were able to narrow down to the answer to this question pretty straightforward. I mean, treat the problem of the patient. He has taken a drug overdosage and waiting and watch at this moment with a ECG showing a gross derangement, and subsequently, I mean, if the ventricles will beat prematurely, the BP will crash anyway. So we are just waiting for disaster to happen. Intervention has to be taken on a priority basis. The next question said a 10-year-old kid had abdominal pain with melena. On examination, palpable purpura is found on the calves and the buttocks. The keyword in the question is palpable purpura. The location is also very clear, extensor on the calves and the buttocks of the patient. So considering the information of extensor purpura and the bleed present, the diagnosis is Henoch-Collin purpura. And he said what drug would be used first line for this case. Even if first line word was not given, initial treatment would be steroids only. Corticosteroids would be answered as the answer to this question. Then he said which of the following is not found in men 2B syndrome, that would be Sippel syndrome. Well, the first American president, John Abraham, had meant to be manifestations, and all of them are, described as M4. So we have a mucosal neuroma, Marfanoid habitus, and even a megacolon presentation. But when it comes to this P, parathyroid adenoma, that would be present in men 1 and in men 2A. We read as triple P for men 1, then 1P goes out and it's PPM, the parathyroid adenoma, and then a pheochromocytoma comes in with a medullary carcinothyroid. So for men A, it's PPM as a mnemonic, and I've described that in the app as well. So I think this was again an easy pickup. Obese woman came to the OPD with dark patches on the neck. So our clinical diagnosis of this hyperpigmentation is acanthosis nigricans, and this would be seen in a patient who is gonna be having insulin resistance. And insulin resistance is what you can even get, or impaired glucose tolerance is what you can get even with metabolic syndrome, considering the options given here. Though other features of metabolic syndrome like centripetal obesity, then teenage lipid profile were not given in this question. Elevated blood pressure values were not given, but considering insulin resistance component is a part of metabolic syndrome. Remaining options, I think, are dummy choices. Addison disease, you would be having hyperpigmentation of the palmar and the sole creases. I mean, Addison disease anyway, the hyperpigmentation occurs in the palms and soles, so that can be ruled out. And the remaining ones we don't read about a hyperpigmentation component. Then was which fluid is shown below. So I think I'll just zoom it in. It talked about calcium also. And then even the values would have been given of sodium, potassium, calcium. So you would have been able to pick it up. And if it is saying lactate, then the answer is pretty straightforward. Though ideally everything on the sticker of the every IV fluid should be known to you, but then considering the presence of calcium in this particular sticker of the bottle, you should be able to come down to the final diagnosis. Coming to the next one, it said a patient who suffered from stroke has now presented with sudden onset flailing arm ballistic movement. I think that was a word that everybody was very vocal about, ballistic movement of the arm. And the movement was occurring in the arm, probably, I mean, this would be forearm, so I'm going to call it arm. And the flailing movement or the ballistic movement would be occurring at the shoulder. So the diagnosis of this patient would be a damage to the basal ganglia. And the involuntary movement that was described was hemibellismus. I'm still looking for other words or other description. I mean, I think the question was slightly longer than this one. So if you can provide me a description, great, hemibellismus, but we can still narrow down to the diagnosis from the current information as well. That would be the subthalamic nucleus. And yes, that's what Harrison says. A violent form of choreiform movements, wide flinging movements. He has not used the word ballistic movement. He has just used the word flinging large movements that mainly affect the proximal part of the body. So I've talked about differentiation. Chorea. Chorea is a fast involuntary movement in the hand. Epitheosis is a slow writhing movement. Slow. Chorea is fast. Epitheosis is slow. Both occur in the hand. But when it comes to hemibellismus, it would be the proximal muscles that would be involved. And the description given in the question was, I mean, everybody was of consensus that the description was of the violent movement that was initiated from the shoulder. That's why I think he used the word that ballistic movement occurring or sudden onset movement occurring. The answer to this one is option number A. So we sort the next one out. This was a kid with epigastric pain, vomiting for past 10 days with oliguria features of dehydration, and peripheral smear shows presence of lymphoblasts. So, I mean, the standard presentation that is given in this case is that of tumor lysis syndrome. Some people also mentioned me that potassium values were given to be elevated. I did not incorporate that because I got that input later on. That potassium values were elevated, serum creatinine was elevated. That made the job of mine even much more easier because when you read about tumor lysis syndrome, all of these imbalances are already present. When this was the first recall, then a couple of guys modified. No, doc. I mean, the question also did mention about these extra findings, so I incorporated them here. And I mean, tumor lysis, the cancer cell will die. Cancer cells are loaded with ATP, right? Energy. So phosphate values would also go up, though it was not given. And then potassium because that's intracellular ion. Then creatinine because there would be uric acid crystals that would be blocking the tubules of the kidney. So I would be having a uric acid nephropathy, and that will explain the acute tubular necrosis that this person is at risk for. And that also explains why there's a oliguria in this patient. And therefore, I would prefer to straight away go in for IV fluids in this patient for the hydration component. This would be the Harrison reference here as well. And also is discussed in blood cancer acute leukemia segment. Uric acid nephropathy, if it occurs, vigorous IV hydration and diuresis would be the first step for management. Other options were like sent for ultrasound. So probably, I mean, I do want to pick up where the lymph, because this could be associated with organomegaly, no? I mean, any blood cancer, because this could be seen with acute leukemia. So the doctor wants to pick up organomegaly, but that ultrasound can wait. And similarly, why did a rule of D is because if I give chemo, the load on the kidney will increase further. I mean, already the cancer is having a high multiplication rate, as a result of which the kidneys are suffering. If I decide to kill the cancer, I mean, this guy has had it. There would be worsening of the manifestations of the patient. So we come to the last one, which said a patient with fever and severe cough pain has presented to you, and there is conjunctival suffusion with petechial eruption and thrombocytopenia. So let's look at the subsequent information. There was a liver involvement occurring and the urine showing hematuria. So it was like this. There was fever present. Then there was a liver involvement in this patient. This liver involvement was contributing to, I mean, the derangement with respect to, I can say, icterus occurring. Then hemorrhagic manifestations were also present. And at the same time, the kidney involvement had also occurred. So when I join all of these together, I can rule out chikungunya, which will mainly present with fever with joint pain, dengue hemorrhagic fever that will mainly have bleeding manifestations. And if there's encephalopathy, when at the moment there was no encephalopathy in the patient, there was no loss of consciousness occurring. And if it was, let me say, viral hepatitis only, viral hepatitis can contribute to bleeding. But then this initial presentation, fever with cough pain, this is when you read the literature, this fever, cough pain, back pain, this is very pronounced feature that you encounter in leptospirosis. So the answer to this question will work out to be option number A. There is one more question that I am not mentioning at the moment with respect to a MCQ statement, because the values of that nobody provided me. I mean, they did said that bilirubin was elevated and serum alkaline phosphatase was elevated, so it will turn out to be obstructive jaundice, because the values told to me were only of SAP that were almost 4 times on normal, with mainly conjugated bilirubin getting elevated. So I'm saying that that was a question on obstructive jaundice. The options were like hemolytic jaundice, hepatic jaundice, obstructive jaundice. So if this was the situation, great. But why I'm not included it in this discussion is because I did not get the exact method. People just said, sir, value यहाँ ध्यान नहीं है. इतना पता था कि bilirubin बढ़ा था. Total bilirubin का concentration was substantially high, going up to almost 80%, and SAP values were 4 times on normal. तो हमने obstructive jaundice mark कर दिया, and I said perfect. I mean, that's what is to be done. So if I can get the values, it would be really, really appreciated so that I can go forward. But because I took up a lot of time of all these people who had come after the exam and they were in a rush to said, sir, ab bas, we can't handle it. So I said, okay, fine. Thank you for your efforts in helping me out with the options. And thank you so much for having the patience and hearing me out here as well. In case you find discrepancy with respect to the wordings of the question or for any options, I'm available at my email marwahmedicine@gmail.com, and I'm very sure all of you will do great in your future life, and all of you are gonna be great doctors. Thank you so much for hearing me.